Now, very interesting study was done called Gysi study. This was an Italian study. It showed that the patient without LV dysfunction, despite the fact ejection fraction was more than 35%, look at the mortality. But one patient with left ventricular dysfunction, with less than 35%, the mortality is much significant. So that's why we consider ejection fraction as a very important parameter. A new classification of heart failure, and please, especially you young people in the basic science right now, the second year, please remember this is the best way of learning about the heart failure. This is called a stage A, means the patient is high risk for developing heart failure. Why? Because they have a hypertension or coronary artery disease, diabetes mellitus, or family history of cardiomyopathy. These are the setup for the patient to end up with a heart failure later on. So this will be called a stage A, where no sign of heart failure, no symptom of heart failure, but the risk factors are there warning you that this patient. This will be called a stage A. A stage B means there is asymptomatic heart failure. Patient again no symptomatic, but has unfortunately experienced the consequences of those risk factors, such as patient had that myocardial infarction in the past, or there is already left ventricular systolic dysfunction because the ejection fraction is low. Right now he is asymptomatic, but we know he has already consequences of the heart disease right now. Stage C means symptomatic heart failure. Patient has symptom at the present time. You have known structural heart disease, you know the patient is short of breath and fatigue, and there is reduced exercise tolerance. Finally, stage D means refractory end stage heart failure, where the marked symptoms at rest despite medical therapy, those who are currently hospitalized or cannot be safely discharged from the hospital, and this will be called end stage. So now you have 4 stages, A, B, C, and D, beside the classification that we use in terms of symptom called the New York Heart Classification 1, 2, 3, and 4. Now, this is the correlation. So this is the stage A, stage B, stage C, and stage D. Now what? Stage C may end up in the mild heart failure, no symptom with normal activity. This is class 1, New York Heart Classification. Class 2 to 3 means mild and moderate heart failure with symptoms upon mild to moderate exertion. And class 4 means symptoms at rest, which is the same thing as stage D. But stage C also can go back and forth from class 4. Same thing. Class 2 and 3 can go back and forth from C. Also, C can go to class 1. So this is how you should understand the heart failure in terms of staging and classification of symptom-wise. How you treat the heart failure? That's the last question. Simple, philosophically understanding is, for acute heart failure, most crucial, improve the symptoms. That's how the patient came to you. He's short of breath, he's got edema, he's got lung congestion. Your, at that time, obligation, responsibility, and the duty to get this, improve the symptoms by treating. For the chronic heart failure, and quality of life, would patient will go back to the job, we're able to take care of the house and children. And finally, one of the obligations also is try to develop newer techniques. How we do that? So we come back to the same thing, take the fluid out, either by putting a toti there or by giving some Lasix something. Now, this is very interesting in terms of the chronic therapy. Are we really, quote unquote, prolonging the life or improving the quality of life? This is the all chronic therapy, is living shorter, living longer. Now, let's just take this one here. Just to give you an example, oral milrinone. What is that? It's an amrinone which increases the contractility of the heart. You give that one. Patient may feel better because you improve the contractility, but also this is irritating the heart. It's like a tired horse. You keep on whipping him. He's already galloping and you're whipping him. May tired more. So they live shorter, they may have more arrhythmia, may die early. What about all these medication? Same thing. Some of them, digoxin, patient feels better, but doesn't affect the survival, neither short nor long. You take some endothelium antagonists. They're making it worse. You take AICD, perfect example, automatic cardiac defibrillator, because some of the people would die suddenly because they have arrhythmia, and you put them, they do longer, but they don't feel better at all, because all you're taking care of the arrhythmia problem. But if you have ACE inhibitors, look at this one here, beautiful, feels better as well as live longer because you have done the decreased afterload, You have also, in a way, prevent the remodeling, which I showed you in the subsequent slides. Same thing, aldosterone blocker, beta blocker. These things not only make the patient feel better, but they live longer as well in terms of the quality of life as well. Now, we add one more. How about the diuretic? Same thing. Biventricular pacemaker. Okay? Same thing. We are pacing the ventricle both simultaneously to increase the coordination, because the reason is because you have scarring and the two ventricles may not be contracting synchronously. So may have, by putting pacemaker both sides, you may improve. Here, same thing again. Some of the important drugs, I'm not going to go into vasopressin and some antagonists. Now, mechanism of effective therapy for heart failure is you're taking care of the renin-angiotensin blockade, you're enhancing therapy, and you're taking care of the aldosterone blockade and beta-adrenergic blockade. These are the four very important parameters that you have to take care of. What about the mechanism of drugs? Some of the drug effects. This becomes a little bit too much, but the only question is just now ideally, because you're giving isosorbate is donating the nitrous oxide, and a small artery dilate, and you do the venous dilator, because you decrease the preload and you decrease the afterload. Hydralazine not only acts as the afterload reducer because vasodilation, but also antioxidant. And Bidil is just simply a combination of the nitrate and the hydralazine. And you can see the impact of therapy on survival. This is the natural history, what would happen if you acute compensated heart failure, if you don't do anything else. At this time, if you give aldosterone blocker, inhibitor, this is the natural history. This is the ACE inhibitor. This is the aldosterone blocker. This is the beta blocker, and this is the also the beta blocker here. You can see how the survival increasing in number of years by this treatment. Okay. Right now, ideally, hopefully, expecting that something would come up which will give a much better one in terms of devices or in terms of the other research that we hope to do to maintain. Lastly, the ventricular dystonia, because I just mentioned to you because of the scarring, there may be ventricle may not contract, and you can see the left bundle branch block appears. So if we put two pacemakers in both ventricles and contract, now you may contract the two vessels better. Hopefully, these will be helpful to you for a long run as well.